This screencast is to go over the theoretical knowledge related to clinical skills for the medical office in Anatomy 1. As mentioned in our previous discussions, and because of the compressed work schedule that we have, I'm going to introduce the theoretical knowledge, but we will practice the hands-on application in Anatomy 2 when we get to visit the nursing labs. In your blackboard, you will have a booklet like this that says Clinical Skills for the Medical Office, Anatomy 1, and I encourage you to read through this booklet because when we make it our way to the lab, the understanding will be that we've had an opportunity to review this. When we talk about clinical skills, we're talking about non-invasive clinical skills, skills that you would be competent to perform in a medical environment under the supervision of both a nurse or a doctor, and they will take responsibility for the skills that you carry out. Secondly, they're non-invasive clinical skills, so they don't fall under a designated medical or designated nursing act. So again, they fall within your scope of practice based on your anatomical knowledge and your understanding of healthcare practices. In a quick capsulation, hand washing procedure. We are going to practice a hand washing procedure, and yes, there is a hand washing procedure. There's a 1 minute, a 3 minute, and a 5 minute hand washing procedure, depending on the procedure that is going to be performed. Most times in a private office, you're going to focus on a 1 minute hand washing procedure. A 3 or 5 minute hand washing procedure is usually involved when a doctor is going into the OR or a nurse is going into the OR and invasive procedures are taking place. When we're simply measuring somebody's blood pressure, their temperature, or what have you, we will follow the aseptic 1 minute hand washing technique. One of the goals when we do perform clinical procedures is that we ensure that the client is aware of who we are and introduce ourselves, and that we practice in a safe manner. The hand washing procedure is designed to rid us of microorganisms or disease-producing pathogens, as we see here in this statement right here. Pathogen transmission, the single most prevalent way it's passed from one person to the other, is a lack of hand washing procedure. Hand washing procedure is designed to protect you as well as the client. It's a two-way mutual beneficial practice. There are places that microorganisms or disease-producing pathogens can harbor on somebody's skin, on our hands, under our nails, in the air that we breathe, droplets, different types of environments set up a breeding ground for these microorganisms. And ideally, a lot of microorganisms grow at the body temperature level. So we are just a breeding ground for microorganisms. So always think about when you're going to have any kind of contact with an instrument, a person, or any soiled or contaminated surface, you're always going to wash your hands and, if possible, even glove. What should a healthcare practitioner do to make sure microorganisms do not harbor underneath their nails? When you do a hand washing procedure, part of the procedure addresses how to clean our nails so that we can remove some of those harmful pathogens. Another important consideration is what should you do if you have a break in your skin. Always cover that area up, because an opening in the skin is an entertainment to a harmful pathogen from coming into your skin and causing disease within yourself. Also, when you have a break in the skin, there could be oozing, there could be bleeding, so you always want to protect that area of your hands or your body that may come into contact. There is a proper sequence that we will practice again when we go into the nursing lab, and we'll focus some time on the hand washing procedure and some of the important considerations. According to the Center for Disease Control, hospital-acquired infections, or HIAs, account for an estimated 1.7 million infections associated with 99,000 deaths in U.S. hospitals each year. So it's astounding that most of these, not all of them, could have been prevented with proper aseptic technique. Another technique that we'll focus on is the measurement of height and weight, how that is important in terms of the overall assessment of someone's health. Measuring their height could indicate if they're actually compressing of the spinal column due to some sort of disease, bone disease, whatever could be evolved. Also, when we're measuring the height and weight of a child or somebody growing, that would be indicative of any growth or health issues. The weight is relevant because a lot of diseases are associated with weight gain or weight loss. So historically, when a patient or client arrives for an annual health exam, their weight and their height is checked for those reasons. Certain medication calculations are based on weights and also observation of medical status. If somebody presents losing 10 pounds and they haven't been trying to do that, that would be a concern for the healthcare practitioner, and that would be noted in the client chart. So we will talk about the principles related to weighing the client. Use the same scale each time. Ensure that the scale is properly balanced and serviced on a regular basis. Have the client void, meaning urinating, before they have stepped on the scale. And oftentimes doctors record it in kilograms versus pounds, but clients often want the conversion for how many pounds do I weigh, and you often will record the kilograms. In 1 kilogram, we have 2.2 pounds. That's the conversion. What I want to focus on the remainder of this discussion is interviewing the client and taking a health history. You want to remember that when clients come into an office, they're going to expect that people who are looking after them have some health-related knowledge and have the capabilities to assist the physician in a proactive manner. Remember, if you're hired in the role of a clinical assistant, you're being expected to make both the doctor's life more efficient and to record accurate information. Well, how do we do that? How do we ensure that the information is recorded accurately and that certain steps are taken to make the visit comfortable for the client and also, like I said, effective and efficient for the physician maintaining their care? As I mentioned earlier, you will do anything related to the client under the supervision or observation of a nurse. So that is a known entity. You would not go into any practice unless that is an understood expectation. Oftentimes, the medical assistant or the clinical assistant prepares the client for the doctor's examination. So you will often guide the client into the examining room. You will often have the chart available to you. Even if you're working with an EMR, you would be pulling up that documentation in the examining room as you interview the client. As we're aware, most hospital locations, most private offices are equipped in each office with a computer application that will launch into the EMR to record the information that you are telling the client or that the client is telling you as a medical assistant. Remember, a chart is a legal document. All information must be documented precisely and accurately. The 8 steps to a successful client interview. Do your research before the interview. Look into the past history before you even go into the examining room or before you call the client in. You will have access to that EMR. For instance, if this client has a history of hypertension, you don't need the physician or the nurse to tell you to measure their blood pressure. That should be a known requirement before you're even asked to do so. Knowing that they have hypertension, when you approach them, you will ensure that you take an accurate blood pressure reading, and that's another skill we'll be practicing in the nursing labs. Plan the interview. Be organized before you start the interview. Make sure you have their accurate record, that you have the right person. Oftentimes you will have families that have the same first name and the same last name, so make sure you're pulling the right accurate record. Make the client feel at ease. Maybe an icebreaker. Ask them how they are today. Ask them a leading question. Try to make them feel relaxed. Give them some eye contact, because many clients suffer from white coat syndrome. As soon as they see you, the blood pressure goes up, and so does the panic. Also, make sure you're introducing yourself to the client and ask them for the interview. Tell them who you are and that you'll be asking them a few questions today prior to the doctor seeing them. Ensure that this interview or this discussion is happening in private and that there's no potential for interruption. Close the door. Do not use pet names with your clients. Be respectful and sensitive of specific topics. There will be clients who will tell you, I want to wait to speak to the doctor to explain why I'm here. Always start off with, why are you here today? Or what brings you to the office today? That will allow the client to open up and give you an idea of what the purpose is. We often refer to that as the chief complaint. Why is the client here today? Is their chief complaint. In the EMR, there's actually a section for the chief complaint to be recorded. And again, with with step number 6, be respectful with sensitive topics. Some people will not want to talk directly to you about these sensitive issues. Recognize that and put that in the notes that the client would rather speak to the physician upon entry. Do not diagnose or give an opinion with step number 7 because that falls out of our skill set and our scope of knowledge. Oftentimes clients will think we're 1 credit short of our MD, and they will think we can give as much information as we can, like a physician. We want to be very clear that we do not offer that type of information to clients. Summarize a general picture when you put your points into the EMR. Best to use point form so that the doctor, prior to their entry to seeing the client, will pull up the record and actually have a quick look at it before they even go into the room. So if you captured accurate information, this will help the physician to know how to target their examination with the client. Methods of collecting client information. This is an interesting section to kind of read over because it gives us some ideas in terms of questions. When we go to the nursing lab, we're going to practice how to ask different questions. I'm going to give you a variety of different scenarios that you will work with, and you'll interview each other and come up with some sort of documentation and history that you're going to record. So some quick things to think about. Encourage the client to take the lead. So that's why you would ask, what brings you here today? That often allows them to open up and give you some idea of what the concerns are. Encourage the client to provide any additional information. So if they come with an upset stomach, ask them how long the stomach ache has been going on. Has there been any nausea? Has there been any vomiting? Try to fill out those kinds of questions because, again, it provides a better picture for the physician. Encourage the client to evaluate the situation. Maybe they will have a lifestyle change that's affect this, a new medication that they're taking. Ask some closed-ended questions that will provide you some limited information. So these are some ideas of ineffective ways you can do it. Ask some leading questions that can sometimes also not get the desired result. Don't challenge the client. Don't argue the client. Sometimes take the verbal cues. If they don't want to be probed, don't probe the questions further. When documenting the client's information, remember the 6 C's. The client's word, the clarity of their words, the completeness of your documentation and the conciseness, the chronological order in which you record it, and of course the documentation that you are securing is confidential at all times. To conclude our overview of the technical theoretical knowledge, remember the SOAP method of charting. We always approach with a subjective, objective, and assessment and plan. The physician will also approach in that method. Recording the client's medical history is often using a questioning technique. We call it PQRST, provoke, quality, region, signs and symptoms, and time of onset. These are all great guidelines to follow when we're trying to record the history, but also even ask the questions. There's a variety of different forms that are used in a client file, and I'm sure when you've been in your EMR course with Anita, you've covered some of these forms, or you will be exploring them further in your OHIP course in the winter semester. Some section of the file will say progress notes, and these are where we record simple visit notes, why they've come in, their chief complaint, and on the date that it occurred. More detailed information about their health history is often recorded by the physician when they interview the client themselves. This is where we will stop and conclude this part of the understanding of the theoretical knowledge related to clinical application. I encourage you again to go into Blackboard and look at the PowerPoint that goes along with this, as well as downloading the guidebook that goes with that as posted. Have a great vacation, and I will see you soon. Bye.